My name is Alistair McNary. I'm chairing this final session, and I'm delighted to be joined by a team of airway megastars. However, before the megastars take the stage, a little bit of advertising for DAS's own meetings. Next year, in 2024, the DAS meeting will be all the way down the road in London, somewhere south of Scotland, I think, London. And Dr. Meir is going to tell us all about it. Dr. Meir, you have 5 minutes.
Thanks, Alistair, for the very nice introduction. So, we are delighted to announce that the DAS 2024 annual scientific meeting will be held in London in 2024. Needless to say, although it's a biased view, but I think all of you should start preparing like now onwards, make plans, come. It's only a 2-day meeting this time, full of stimulating talks, discussions, opportunities for social networking. The gala dinner will be at a very iconic London venue, certainly not to be missed. So for those of you who are local, you might have seen the Guildhall, which is very centrally located, a very historical building right in the center of London, has huge halls, historical value, and has its own museum right next to it as well. There are lots of spaces for trade stands, for the scientific program, the faculty kind of spaces as well. And as you can see, geographically, it's right in the center with at least 3 underground stations and a train station right next to it within walking distance as well. There are lots of hotels centrally located close to the venue as well. So actually, there's absolutely no excuse not to turn up for this meeting. It's very commutable, it's quite central, and it's going to be in a very nice time of the year, right close to Christmas. The gala dinner, as I said, will be held in the House of Commons. We have reserved a space. What I will say about that is the spaces are very limited because of security reasons. So if you do want to attend, it'll be first come, first serve. So please do make sure you book your tickets in advance. There will be a guided tour of the House of Commons as well. For those of you who attended the 2017 meeting, this was a hit then as well, so we've kind of replicated it again. There'll be abstract posters, lots of opportunities to present your latest projects and research work. And the last but not the least to say is we've been really lucky to have a very super special organizing committee this time. So we've got between the 8 members of the organizing committee, we have experts who organize WAMM 2015, WAMM 2019, and now WAMM 25 as well. We've had DAS 17, 18, 21, 23, and the GAMSI meeting in London. All of those experts and organizers are within the organizing committee. So surely that's a great sign that it will be a meeting not to be missed. So make plans now. Save the date. It's 28th and 29th of November, 2024 in London. I hope to see you all there. Thanks.
The organising committee by recognising my picture, but we have an extra taster for you this year. The World Airway Management Meeting, as you know, has been organised by Eleanor Sullivan, Betsy Beringer and Anil Patel for 2 iterations. It's coming back post-COVID in 2025. Professor O'Sullivan, you also have, you have 2 of you. You still get any more time. You get 5 minutes together.
Thank you very much. Now that you've your diaries out and you've put the London DAS in your diary, think a year ahead, because WAMM is coming back to town. We had the one in Dublin, as Al said, in 2015. And that was our first kind of toe in the water. We did it with the Society of Area Management in the US, and it was a big success. We had, I think, 1,300 delegates, and we had a fantastic educational and social event. People said, let's do it again. So 4 years later, we did it in Amsterdam. The Amsterdam meeting was really good as well, in another iconic building. It was the old stock exchange in Amsterdam. and it was again deemed a big success. Just stats, we had over 1,800 attendees at that one. We had 21 expert sessions, which were very popular. We had 300 airway groups. We set up an airway village, so anybody in airway groups from around the world could get a slot for free and kind of mingle with all of us. And that was joined with DAS, SAM, and European Airway Management Society. And then we were so, we said we'd do another one, but then COVID hit, so we put it on the back boiler. And now 2025, 10 years after the first one, we are coming back to have a meeting. And a lot of work went into where we would have it. So I'll hand over now to Neil to announce where it's going to be.
Well, we have great pleasure in, one, hopefully showing a video, which will come on, and we're going to see where this lands, and it's going to land in this amazing city of Florence. We're absolutely delighted to have the third WAMM, which will be the 20th, 30th anniversary of both SAM and DAS, respectively. For those of you that I'm sure many of you will have been to Florence, Ellen and I had the privilege of going there and having a look around the venue. It is absolutely stunning. Dublin was great. Amsterdam was great. I've never seen a venue in a city quite as beautiful as this. Absolutely stunning. The venue itself is a state-of-the-art, very new facility. But it's surrounded by history and culture. It's surrounded by a fort that was built by the Medicis, which you can go down into the cellars and tunnels for. Obviously, Venice itself is Florence itself is quite a small city, so you can walk around it. It accommodates people incredibly well. So I think they have about 700,000 people that live in Florence, and they get anywhere between 10 and 15 million people visited. So they get hospitality. It's amazing. This is the Medici fort. Inside, the facilities are world class. It's going to be a great meeting. We had 1,500 and then 1,800, so hopefully we'll get 2,000 this time round. We had 40 countries, 70 countries, hopefully we'll get 100 countries represented there this time round. If you like culture, amazing. If you want to see Da Vinci, the Annunciation, you can see it. If you want to see Statue of David, Michelangelo, you can see it. If you want to see Botticelli's The Birth of Venus, you can see it. You can get culture, hopefully a bit of science, and hopefully a bit of airway knowledge as well is imparted. So delighted, Florence.
Right. And just the dates, the 5th to the 8th of November. It's a bit slightly quieter time in Florence, but apparently the weather is still quite nice. And so put that in your diaries, and we hope to see you there. There's a great social event as well, we hope. We're just kind of finalising the details. In a venue a bit like Guinness's Storehouse with lots of different foods and kind of interactivity, so we're working on that. So if it's in the diary, you'll be there 2025.
But London first.
London first.
So I'm getting the feeling the two professors have finally finished. The take-home messages are London 2024, be there. Florence 2025, be there too. What more can I say except to thank the organisers for giving me this session with 3 untamed presidents of airway management societies and only 1 chair. The good thing is they were all introduced to you during the last session, and so without much further ado, I'm going to ask the New Zealander, Paul Baker, to stand up and speak from an American perspective on his case. If we could have some lights up on the audience, because this entire session is meant to be interactive, and the rules for interacting with the speakers are you get 1 sentence at a microphone, or we'll find a friendly taser to get rid of you. So short questions and short answers and short comments are the way we're going to do this. Paul.
Alistair, thank you for that introduction. One minor correction, and you're forgiven, but the Society for Airway Management is an international airway society. 2/3 of the members are from America, but the other third come from all over the place. And I am the current president, and I come from New Zealand, not from the United States. Minor point.
Kiwi of some sort.
So I'm talking about a case concerning an exit procedure. It's a paediatric case. I have conflicts there, and also I have some, Alistair asked me to put in some learning points. I'm not going to go through these, but if you're interested, they're available for later on. So the case report concerned I'll read it up here because I can't read that very easily, I'm sorry. This was a 33-year-old woman, and she had an antenatal ultrasound at 19 weeks, and it showed a fetus with severe micronathia, ear abnormalities, and polyhydramnios, all which you would expect to see with a first branchial arch abnormality, and the polyhydramnios is associated with that child's inability to swallow properly, and that was the outcome: severe micronathia, ear abnormalities, and this poor child was born with airway difficulty from birth. And the woman went on and she had two previous pregnancies leading up to the case that I'm going to present. But the first child was a boy, born at 38 weeks, severe micronathia, that's the boy, and ear abnormalities. And at 17 weeks, he had to have an emergency tracheostomy. The second pregnancy was 4 years later. Following a lot of genetic counselling, she wanted to have another baby. It was suggested to her that everything would be all right. She could have a normal baby. So she went ahead with the pregnancy. Unfortunately, that baby died of an abruption, and it was a normal baby. So she waited, had more counselling, again told you can have another baby, went ahead, and unfortunately this baby had the same syndrome as her older brother. And we had a discussion, a group meeting about this, the safest way of delivering this baby with a virtually unintubatable airway with chances of airway obstruction on birth, and we decided to do an exit procedure. So just some scans to show you what we had at the time to make the diagnosis. So this was ultrasound, and you can see the profile of that baby on ultrasound, and there was polyhydramnios around, and a reconstructed scan showing virtually no jaw. This baby had a terrible looking airway. And there, another scan. So we had a pre-planned strategy after a meeting, a multidisciplinary one. Obviously simple principles: maintain oxygenation throughout the procedure of the delivery, and a cascade of techniques was planned for tracheal intubation, and it was going to be done as an exit procedure. So the question is, what is an exit procedure? It stands for ex utero intrapartum treatment. It's basically baby on bypass. So you deliver part of the baby, the head and shoulders, while maintaining uteroplacental perfusion, and that can go on for quite some time, up to an hour. And during that time, you can secure the airway, and then once that's done, of course, you can safely deliver the baby. It requires uterine relaxation, so it's the reverse of everything we learn as registrars doing obstetric runs, of making sure that you have good contraction, etc. So you want a flaccid uterus, you don't want the placenta to be separated, and you don't want the uterus to start contracting. It also involves fetal anesthesia, and that is done by placental bypass. The drugs from the mother wash through to the baby. We devised tracheal, the indications for the exit are tracheal occlusion at birth, and it was originally designed because of diaphragmatic hernias. And so it was found that if you occluded the trachea, and this was done on animal studies on rabbits first, if you occlude the trachea in utero, that the lungs will mature properly and the diaphragm will settle down. Whereas with the diaphragmatic hernia, the lungs can't mature because the contents come up and affect lung maturity. So that was the first one. And of course, if you're going to tie off the trachea with fetal surgery, you have to untie that just before birth, and that's where the exit procedure came in. So it's for fetal neck masses, conjoint twins, congenital cystic adenomas, congenital high airway obstructions, unilateral pulmonary genesis, and then we added to that list, ours was the first, severe micronathia. So the consideration for our exit procedure was the antenatal diagnosis. It was a pretty clear diagnosis. And the exit procedure was based on also genetic evidence. The maternal risk factors were there. There are risks to the mother of bleeding and early separation of the placenta. And there are neonatal risks, so the baby may die during this procedure. The exit anaesthesia, well, it's based on maternal GA and a prolonged induction to uterine incision time using a volatile agent in our case, although there are examples where they use regional anaesthesia, but you must have a relaxed uterus. Uterine ultrasound was the way of mapping the placenta to make sure you didn't upset the placenta during the procedure of the caesarean. Maintain uterine volume because, of course, as soon as you open up the uterus, placental fluid flows out, so you have to replace that with a saline infusion, warm fluid. And then you deliver the baby's head and neck. Our plan was pretty basic. We thought maybe, despite the evidence, it could be an easy intubation. That took a few seconds to realise that was not going to happen. And then we had a senior ENT surgeon who was very familiar at doing rigid bronchoscopy, and he declared he'd never failed with a rigid bronchoscope. So he popped in a rigid bronchoscope, and we moved on to the next plan. And that was with a flexible bronchoscope, and we had planned, if that all failed, to do a tracheostomy in utero. Now, this was in our older hospital. We now have a lovely new paediatric hospital, but you can see in there were 26 people. Not everybody was essential, but it attracted a lot of attention. We had allocated tasks for the people involved. And this was the ENT surgeon attempting direct laryngoscopy for a few seconds. And this was the ENT surgeon with the rigid bronchoscope. And you see a paediatrician is actually holding the umbilical cord away to make sure that's adequately perfused. And then yours truly tried flexible bronchoscopy, having placed a supraglottic airway as a conduit. Now that I thought might be straightforward, but in fact I forgot my physiology. There was actually a lot of amniotic fluid around, obscuring my view. So it took some time to clear that, and it kept on welling up. But we cleared that away and managed to intubate. I had two size 3 tracheal tubes rammed together without the connectors on them to lengthen my tube, place that through the supraglottic airway, and that enabled me to take the supraglottic airway off and the proximal tube left with the distal tube in the trachea. So that's the baby being intubated through the supraglottic airway. And we end up with a size 3 tracheal tube, and at that point the baby was delivered and then taken into an adjoining operating room for a tracheostomy shortly after birth. One of the paediatricians said to me, "What happens if that tube falls out on the way to the theatre for the tracheostomy?" And I said, put in a laryngeal mask, and to my absolute shock, he said, "What's that?" So obviously the paediatricians at that stage weren't using supraglottic airways. I think things have changed a bit since then. The baby had dysnathia complex with an extraordinarily rare condition. Hyperplastic or absent mandible can happen. Our baby had virtually no mandible. Microstomia, microglossia, and ear abnormalities. And there's the MRI scan of the baby, and you can see the profile there with a pretty shocking looking mandible. The incidence is extraordinarily rare. 6 were born at that time, were stillborn. 8 died shortly after birth, and only 7 survived infancy. All survivors required a tracheostomy. And the principles of the safe airway management for this baby was airway assessment. So that's where our ultrasound came in, plus knowledge of the history and the genetics. We used pre-planned strategies. We had a team put together, a maintenance of oxygenation provided through the placenta, avoidance of trauma caused by repeated intubation attempts. There weren't too many of those. Confirmation of tracheal intubation using capnography, but also we had ultrasound, It actually is quite difficult to monitor these babies when they're covered in vernix and lots of fluid around. We had an extubation strategy that was to replace a laryngeal mask, and we reported the case. So here's the product of all of our efforts. A lovely little girl. She has now graduated from university with a degree. She's gone on to have a normal life. Thank goodness to that exit procedure. So, thank you.
Paul, thank you very much. You're not allowed to go away yet. As an entirely adult anaesthetist, most of that presentation had me squirming. But we've all been on labour ward when somebody turns up from St Elsewhere's without the maternity notes, but they say they've got a bit of complex obstetric history. What are your basic? What should we be thinking when people turn up in our obstetric? What's the basics of airway management for tiny neonates, for the adult anaesthetist?
For an adult anaesthetist that has an obstructed airway, are you saying?
Yeah.
You're called in as...
Yes, you're called in as an adult to see a child.
Right, yeah, and actually I have some knowledge about a similar circumstance, and it's a frightening, terrifying experience for that poor anaesthetist. But I think you have to do something, and the collective opinion is a tracheotomy, which I think I showed in my previous lecture. Don't fiddle around with needles and other techniques. So it's a longitudinal cut, dissect down to the trachea. It's remarkably superficial in the midline. You can easily bypass it. Use blunt dissection, find the trachea, do a tracheotomy and place a tube, or put a bougie in and slide a tube over it. That's the plan. I'm not saying that's easy, but it's that or nothing.
That's the plan. And given this is meant to be an interactive session, does anyone have a short comment or a short question they'd like to make? Please come up to the microphone. Please stick your hand up because I'm old and blind and can't see you. One over there. Yeah.
No, we didn't consider that, but I thought that might have been extremely difficult as well. I don't think there were any easy options. If we delivered this baby, it was a high chance that baby would have died.
Gosh. And any more? No. Paul, I think you're off the hook. Thank you very much for that wonderful presentation. Thank you. Next up is Professor Eleanor Sullivan, who, I'll get this right this time, who is from Ireland, but did quite a lot of her training in England and is now back in Ireland, and apparently is organising some meeting in 2025 she'd like you to go to. But we're here to hear about her case this afternoon. Thank you.
Good afternoon, everybody. I'm going to present a fairly quick case. This case is a case of a 69-year-old man who arrived by ambulance to a small DGH A&E at 2 in the morning. The story was that he'd woken up during the night, progressively dyspneic and kind of developed stridor. The ambulance got there. On the way to hospital, they thought he was having an exacerbation of his COPD, and they gave him some inhalers. He had a history of COPD, ischemic heart disease, and his BMI was 50. And the diagnosis, when he got into A&E, they felt he was having an anaphylactic reaction. They gave him adrenaline, and then he started to deteriorate. So they urgently requested anaesthetic assistance, and 2 registrars arrived. One was a first-year registrar on the trainee scheme, and the other was a sort of standalone registrar with much more experience. The vital signs were, as you can see there, respiratory rate was high. His SATs were down at 70% on oxygen, and his blood pressure and heart rate were okay because he'd been given some adrenaline. But he was in severe respiratory distress. He was terribly agitated and becoming very unresponsive. When the 2 anaesthetists arrived, they said he was kind of peri-arrest. They tried kind of basic airway manoeuvres. They tried mask ventilation with no success, and then he started to deteriorate dramatically, becoming bradycardic, and he was seesawing. So what next?
I think that's going to be one of those role play questions. So if you want to stick your hand up and volunteer what you do next. I wonder whether high flow would have been an option in your casualty department, Professor, but probably not. So who wants to have a punt at what we should do next? Absolute silence.
Okay. Oops.
Well, you now know what you're going to do next. So.
Right, so they felt they gave him propofol and succinylcholine because he was so agitated and that this might improve their efforts. They did a direct laryngoscopy following that and revealed grossly abnormal epiglottis. He then deteriorated further, losing his output, and they started CPR. They then did a second laryngoscopy, still with the DL, as no VL was available, and they got no view and deemed intubation impossible after that second attempt. Any suggestions what they might do next?
What's that? Sorry, the murmuring. Just yell it out. Okay, so stick your hand out. So somebody's saying oxygenate? How? Supraglottic airway device. What sort of supraglottic airway device? Remember Professor Cook this morning? Second generation of some sort on iGel. Okay. So one says iGel. Anything else? Any advance on an iGel? Front of neck. Should you do an iGel before you do front of neck?
Okay, I'll move on. No view, as I said, so they didn't do a third laryngoscopy because they had nothing else. They hadn't a VL and another device, but they went on and discussed supraglottic very briefly, and they decided to do one or the other front of neck access. Because of the view being a very swollen epiglottis, they felt they wouldn't put a supraglottic airway in, but we can discuss that in a minute. So it was now after 2 in the morning. There were, as a consultant en route, as I said, it was a district general hospital, 2 regs, one of first year and the second much more experienced. I think he had 6 years more experience, no ENT on site. So the question is, who should do it? And that's who should do the scalpel cricotiotomy.
So what's the vote? Who thinks the first-year registrar should do it? That's confidence in our trainees. Who thinks the 6th-year registrar should do it? Okay, so rank has its privileges, but should the best person in the room not do it? The one who felt more confident. Okay, somebody was talking about being confident being the solution earlier today. What about training? Does training count, or is it just confidence? So what happened?
Okay, so basically, just saying they had two attempts, failed, they moved on quickly, they didn't do the plan B for the reasons I said, so they moved on to plan C, and they had their last good attempt, face mask ventilation, and that was unsuccessful, so they followed the guidelines. They just checked that the consultant wasn't on the way. Was there any surgeon around? No. They declared CICO, and then they did a scalpel bougie tube. Just with regard to the supraglottic airway device, they didn't attempt to put it in because they felt the degree of airway swelling would prevent it sealing correctly, which was probably true. But this research done by Tom Drew and Conan McCall suggests that placement of supraglottic may assist, even when you think it mightn't work, it will assist with identification of the cricothyroid membrane during ePhona. So you should always try and put one in, and it elevates the cricothyroid membrane, and it's always a good move, even if you've primed and you're planning to do an ePhona. They asked for the equipment. I'll say the more junior, I'll tell you why, the more junior reg did it. He asked for a scalpel bougie tube, which wasn't kind of kit ready, but they had that in the A&E department. He extended the neck. He identified the cricothyroid membrane. How did he do that? He did the laryngeal handshake, which was Richard Levitan. Have you just walked in? Richard Levitan described on cue. described as to identify the cricothyroid membrane, but it doesn't, in research since, it doesn't identify your cricothyroid membrane for you, but it does identify the midline, and it's always worth doing it in the guideline, because this man was obese, morbidly obese, so you need to find the midline before you do your scalpel cricothyroidotomy. The DAS guidelines are very didactic about this. If you can palpate the cricothyroid membrane, you can do your horizontal incision. If you can't, you do your vertical incision. And that's exactly what this very junior trainee did, because he could not palpate the cricothyroid membrane. So he did the vertical incision, and he followed the guidelines. He made a big incision. 8 to 10 centimeters is the size of your credit card is 8 centimeters, and if you even bigger than that, coded cephalad, and that's what the guidelines say. We published those in 2015, but again, since then, there's been work done by Fennessy, which was published in the BJA, looking at this and looking at the optimal length of that incision. It's kind of done, and that's the optimal length of an incision to make sure in a fat neck that you can't really palpate the cricothyroid membrane, that you can find your cricothyroid membrane. You will not miss it if you make an 8 to 10 centimeter incision. And remember, it's a big incision, and you have to be confident to do that. And this trainee, in fact, did that. And he did, these are his comments: the field quickly filled with blood, and despite suction, there was no view. I did blunt dissection using my fingers. The thyroid cricoid cartilage and the cricothyroid ligament were easily recognizable on palpation, and he did transverse stab incision to the cricothyroid membrane. Only the bubbles of air, he said, were a reassuring sight. So he twisted the blade caudally and put a bougie in, and then put a cuff tracheal tube over the bougie. Got capnography. The SATs were slow to come above 90 for the minutes following this, and he auscultated and had put the tube in the bronchially, which is quite common if you're using kind of a long tube over a bougie. Something to be aware of. The ENT consult came hours later because they don't have resident ENT. Obviously, it was epiglottitis, and it's a conventional intubation was almost certainly impossible. 16 days following this patient was successfully extubated. In fact, they never removed the ET tube, but the ENT surgeon wasn't happy to create a tracheostomy. He felt it would be too complicated. But anyway, he was fully neurologically recovered. He made a full neurological recovery, a normal speech, and went back to help look after his grandchildren. So it was a successful ePhona in a patient who had arrested, which I'll ask Tim the numbers on that, but I think that's quite rare. And so why did this patient survive? This patient survived because of this trainee, Jack, who gave me permission to present this. So one of our trainees, he had done an ePhona training on a mannequin in I think the 6 months before that. And that's because it's compulsory in the college. So I think with this, it was very good decision making. The most experienced person completed the task. I think it highlights the value of training. And I really presented for the trainees in the room to make sure everybody gets trained and does training. And even the consultants, because we will all maybe see this once in our careers, if that, and hopefully not more often. And the value of the guidelines. Our guidelines, I think, are didactic, and they easy to teach with available equipment. And we heard that earlier when we were talking about cognitive aids. And the BJA is 100 years old this year, and Craig Lyons, who's here, and myself did a review of airway-related papers and how they were cited, which were the most cited over the 100 years. And this was the most cited paper in the 100 years of the BJA. And I think if you see there as well, it says, anaesthetists should be trained to perform a surgical airway, and they're repeated at regular intervals to ensure skill retention. We heard about that earlier. How often should you do it? Maybe 6 monthly. And that followed with this statement from the ENT and so forth, that scalpel cricothyrotomy should be learned and regularly rehearsed by all anaesthetists. And are we doing that? In our college, we've made it mandatory for trainees. They cannot finish their training without attending airway training days, and one or two, but we do them yearly, so they often have repeat training. We now do it because we weren't getting around enough of the non-trainees as well. We do kind of a masterclass from the college, and we have a central point where we set up the training, and then we video it out live to 12 sites interactively, so you get a lot more attendees every year, and the trainers on the sites are also refreshing their training. So we think this is very important. But I think we should all be doing this as anaesthetists. We should have mandatory training. And I know the Australia College has mandatory training, and the New Zealand College in EFONA. I don't know how often they have to repeat. I think it's every 5 years, isn't it? They have to have it. And I think our college, the Royal College, is also my college. I think we should be moving in that direction, and that everybody should be trained. And we heard earlier about this Sullenberg's flight 1549, which he ditched in the Hudson River in 2009. And he said himself, one way of looking at this might be that 42 years I've been making small, regular deposits in this bank of experience, education and training. On January the 15th, 2009, the balance was sufficient so that I could make a very large withdrawal. So I'm sure that was the first time, obviously, he did it, but he had trained in it. Many pilots probably never do it, but I'm sure they receive regular training in how to land a plane on water. So we really must, I think, grow up, and we must make airway training mandatory. Anaesthetists should be the best can be at airway management. And I think Jack, having had a course, was the only person in this small district hospital that could have done that. If he wasn't there, I'm sure that patient would not have survived. Thank you very much.
So, as usual, Professor Sullivan, you don't escape. Back you go. So there are really three strands. I'd be really interested in anyone who has a question about clinically doing this or being involved in one, or a comment. Obviously, there's a hint of politics about mandatory e-FONA training. If you have a one-sentence comment on that, that will be enough. And there's a question for actually, are we brave enough to say to someone more junior than us, you do it, you've been on the course. So first thing first, to get you all active, who's had e-FONA training in the past 5 years? Keep your hand up if you had it within the past 2 years. Keep your hand up if you had it in the past year. And your hand still up if you had it in the past 6 months. 3 months. And earlier on, we were told it skills deteriorated in 1 month. Anyone had it within the past month? Okay, so some of us will be okay this evening. So any comments or questions for Professor Sullivan? Dr. Ahmad, as president, do you have a comment on the mandating of training? He clearly does, because he stood up. He could have just said no.
No. Well, I think it's a thing we should strive for, but it's how do we enforce it? That's the challenge. I think, first of all, trying to deliver it is going to be a challenge, and then there will be people out there who think they don't need to do this or don't want to do this, and how do we enforce it? So there's a couple of challenges we need to overcome before we can mandate it, I think.
It probably needs to be linked with revalidation. I mean, some of us have to do compulsory fire training, we have to do BLS, ATLS, and things like that. So I think it has to be linked with, it has to be some stick, isn't it? Yeah.
Paul, I notice you're being very quiet. Yes. And ANZCA do mandate this. How do they achieve the numbers?
Well, we have mandatory modules that we have to complete in 3-year cycles, like CPR, anaphylaxis training, major hemorrhage, and frontal neck access is the other one. So you have to go through those cycles, and you don't get accreditation and you don't get registration from your medical council if you don't complete that CPD training. So it is quite strict, and it is one of the essential skills expected of an anaesthetist.
Does anyone have any questions on the case itself? I can see a Dr. Mushambi, who is racing towards the microphone.
Hello, thank you very much. Just to comment about the appraisal and revalidation. As a previous appraisal and revalidation lead, I was conscious that the Royal College of Pathologists had requirements that their pathology consultants had to achieve every year in order to be for the next appraisal. I think our Royal College of Anaesthetists probably needs to get on to that and do the same. If the pathologists can do it, why aren't we doing it?
I suspect probably for reasons Dr. Ahmad had suggested earlier that actually organising that would be really difficult. Does anyone have mandatory provision of e-FONA training in their hospital? I can't see anybody out there. Somebody's got their hand up. Oh, they're waving. Excellent. Would you have a question, sir?
Yes, I just want to share about the mandating of the e-FONA training. I think it has to be mandated, and it should be the initiative who's going to set an example in healthcare in mandating such training like the crew resource management in airline. So we at Cleveland Clinic Abu Dhabi have managed to do this for our whole team without any extra cost or extra time being spent. We provided a flexible kind of a training, and we got the idea from Dr. Fiona Kelly's T-Trolley project. So, and we are going to do this every year, and we are also hopeful of introducing other areas of training as well in a similar format, like the avectracheal intubation. So I really appreciate if this becomes a mandatory and authorized by the Royal College so that we can have a crew resource management kind of training and our skills are up to what the patients expect us from.
Excellent. Any other comments from anyone else? If you wanted to continue that debate later this evening, I'm sure you can. And I think, Professor O'Sullivan, you're off the hook. Thank you very much. So our last physical speaker this afternoon, you have met before, because I can probably pronounce his name and his country of residence incorrectly. But Kemal Tolga is the incoming president of the European Airway Management Society. I used to say he was from Turkey. I think he is from Turkey, but he now practices in Qatar. But he's going to bring us a case, and I think it's no mean feat to come to a meeting like this and present probably your third or fourth language. I'm very impressed by that, so you're very welcome with us this afternoon.
Thank you very much for this presentation. I'll start. So good afternoon, everybody, again. Well, in my case presentation, I have no conflict of interest. So let's look at the characteristics of this presentation. So we have a gentleman, 45 years old. The BMI was 27. The patient had a history of frontolateral vertical hemilaryngectomy 5 months ago, and afterwards a history of radiation therapy. And now the current situation was primary recurrence in the pseudo-right cord area, and the planned surgery was punch biopsy. Well, the patient was evaluated in the pre-operation clinic. So the Malampati score was 2, the mouth opening was 4 centimeter, the neck extension was all right, just there was a scar about 3 centimeter on the neck because of the previous tracheotomy. The dentition was all right, the temporomandibular joint mobility was all right, thyromental and sternamental distance, they were all in normal ranges. So would you do anything else for these patients? What do you think about? Sorry? Check the jaw protrusion, yeah. Nasendoscopy, okay, thank you very much. So we performed the nasendoscopy, actually, and this was the view. What do you think about this nasal endoscopy?
I'm going to change that question, if you don't mind. I'm going to say, how does your airway management change, or how does your airway management influenced by what you see on this nasendoscopy? Because you're seeing exactly what the anesthesiologist saw. What are you going to do about it? Sit and hope someone else says something first. Awake, awake. Anything else? Anyone not want to do an awake? Okay, are you all alive? I think that's a vote for an awake. No one's saying they don't want to do an awake.
Yeah, so when I see this nasal endoscopy, so I was not comfortable, so I decided to talk to the surgeon for the awake techniques and also for the patient also. I declared that the patient had a surgery for the laryngeal cancer. There's a history of radiation therapy. So there's now recurrent TM growth. When I give him the neuromuscular blocking agents, so I have concerns if I'll be in trouble because there was asymmetry in the nasal endoscopy. It was seeming to be prone to pulmonary aspiration. So I talked to the surgeon, and he just said that, no, everything is clear. So you can see the nasal endoscopy, so every anatomical structure is obviously there. So glottis, the glottic opening, so inlet of the larynx, so everything is there. So I don't think so. Well, I was in a gray zone. I was still thinking about the awake techniques, and I thought that it could be difficult to intubate. And as you mentioned, so I was thinking about the awake fiber optic techniques or awake video laryngoscopy, maybe tubeless surgery, tubeless ventilation, or as a backup intubation under GA or tracheotomy under local anesthetics.
Okay, let's just see if they're awake out there. A straw poll. Who wants to do awake flexible bronchoscopy? Who wants to do awake VL? Still not as popular as awake flexible. Who wants to do strive high? Jet ventilation? No takers. Intubation on the GA? One taker.
Two takers.
Two? Can't see anybody up in the gods. Anybody want to do a tracheostomy on the local? Pardon? Could you not thrive them? Okay, we'll add thrive. Who wants to do thrive? I can't see any hands up for that option, by the way. Right, and let me get this right. The surgeon said this was going to be straightforward.
Yeah. So I talked to the patient, and all the awake techniques was refused by the patient. So, and then I went to the surgeon again and asked him to do under local anesthesia to tracheotomy, perform the tracheotomy under local anesthesia. And it was refused by the surgeon. He told me that there's no surgical indication, obviously not. So you saw the nasal endoscopy, so every anatomical structure are clear there. And it's a short procedure, only a few minutes, and we'll just do the pump, the biopsy. And you are an experienced anesthesiologist. I never saw that you failed. And I'm here also if there's any failure, so I can do the surgical fauna, no problem.
Can I stop you, by the way?
Yeah, sure.
I want to ask the crowd. If somebody refuses an airway management technique that you recommend, what do you do? Let's pick on some senior people. Is Barry here? Where's Barry gone? Oh, you're here. Barry, you know about ethics. What's the deal? If the patient says, I don't want an awake, what do you do? Ooh, that sounds appealing. Book leave. I like this. Okay, so the patient has refused. The surgeon has refused to do a tracheostomy. Is that you're telling us the truth here?
Yes, he refused the tracheotomy.
Cancel the patient? He did that yesterday, they're back today. Professor O'Sullivan's going to butt in here.
There might be a genuine reason that the surgeon doesn't want to do a tracheostomy because it does stage the cancer further.
Do you want to say that again? I don't think you can try that.
Just there might be a particular reason some of my surgeons don't want to do tracheostomies at a particular staging of the cancer. It can progress them very dramatically, and you'll know more about that as well. But and a refusal is a bad term, but sometimes they say they would prefer not to do a tracheostomy for that reason. Was that the reason he gave?
Yeah, one of the reasons was that, yes.
But I think they also made out that it was a straightforward view and you should get on with it.
Yeah.
No fun. Anybody else want to comment at this stage about what they do? Okay, that's 2 days in a row the patient's been cancelled. They're still here on the third day. We have to We have to do something.
And it's a cancer surgery, so we have to proceed, they are saying like that.
So what did you do?
So,
sorry.
first of all, after all these discussions, I felt myself alone inside the operating theater, so in front of all ENT surgeons, all anesthesiology residents, so everybody. And I thought again and again, and I decided to identify the cricothyroid membrane, start pre-oxygenation using the high-flow nasal cannula oxygenation, and I started TIVA with REMI and propofol infusion with TCI with a full dose of rocuronium. And there was an impossible face mask ventilation. I said, yes, I knew that it will come here, so all my education, all my family, all my career, everything passed from my eyes. I was very angry with the surgeon, with myself also, so I should do something. And I tried the video laryngoscopy, but there was a collapse of the soft tissue surrounding the upper airway. So almost I couldn't see anything. Hardly I was seeing the tip of the epiglottis, but I couldn't proceed. So what's next? What would you do?
Oh, someone's got their hand up. Even better. Shout out loud. Okay, you can't go backwards. You have to go forwards. Okay, so someone shouted out a sleep fiber optic. Any advances on a sleep fiber optic? Pardon? A video-assisted fiber optic?
As you realize, the SPOT is dropping down.
So we have three options down here that you can choose from, Kamal. This is good. We have sleep fiber optic, we have intubation through the LMA, so rigid laryngoscopy by the surgeon. Is the surgeon prepared for that, given he thought it was going to be easy? He's probably in the coffee room.
You'll see.
A cannula cricothyroidotomy. Has to finish the case first. I think we'll stop the sats going any lower and we'll find out what happened.
So we decided to try another back valve mask ventilation with an additional dose of neuromuscular blocking agent and try to place the supraglottic airway device, a second generation iGel. But during this period, the SPOT dropped to 85%, and there was an increased rate of heart rate to 150. And our aim was placing the iGel and intubation through the supraglottic airway device. But unfortunately, when I placed the fiber optic scope, the view was like that. So grade 1 prima combe. So what was the main problem? What do you think? Or what is next?
Does knowing what the problem is help? Or do we just need to oxygenate the patient?
Now we can hardly oxygenate the patient. The patient saturation is maintaining in 85%, but fiber optic view is like this.
That's 3 votes for front of neck.
access.
Can't hear you, I'm afraid. Louder. And Professor Solensen, get the surgeon back. Who should do the front of neck? The anaesthetist or the surgeon? Thank you, Professor Fruck. You were at least listening to the second case.
Alistair,
Yep, go
I
ahead.
know this is not a popular opinion, but what if you just change the type of supraglottic airway? I mean, these things don't all handshake with the hypopharynx the same way. I know this is an unpopular opinion, but in the United States, we have the double ballooned airways, and I would never use them. But I mean, you know, you guys invented the LMA. Come on.
It's an option. Thank you
That's
very
an
much.
opinion from America. We'll just leave it there. What did you do, Kamal?
So the main problem here was the airway collapse. So as Dr. Rabi also in the morning mentioned, so in this type of surgeries, frontal-lateral vertical partial laryngectomy, so after giving the neuromuscular blocking agent, the soft tissue collapsed and obstructed the whole airway. And we decided to perform a rigid laryngoscopy.
I'm feeling uncomfortable in my seat. What did you do next?
Okay, so this is the video of the rigid laryngoscopy. By using this rigid laryngoscope, so we try to lift up all the soft tissue and to visualize the inlet of the larynx. It was bloody, edematous, so we tried to place a tracheal tube, but we couldn't.
I'm going to make these two tell you what they're whispering about.
Well, it seems to be an airway there, and we're talking about passing a bougie and intubating over that.
True.
At least there seems to be some sort of an orifice.
Hang on, speak up.
Yeah?
Do you think you have a fibroscope ready with a tube on it, ready to go? Okay, keep going.
Well, we placed the Prova catheter, and we started the ventilation with the Prova catheter. And by the way, our superhero surgeon put the tracheotomy while we are ventilating the patient with the manual jet ventilation. And the patient survived. Well, what I learned in this case, so there were two different subjects. So one of them was a radiotherapy, the other one was a previous airway surgery. So in this type of surgeries, so both back valve mask ventilation, supraglottic airway insertion, and the tracheal intubation might be difficult. And another thing was about the human factors. So our surgeon was lack of situational awareness, but at the same time, I was a lack of communication, good communication skills, and the teamwork also. And according to the NAP4 study, the human factors was related about 40% of the failed tracheal intubation. They declared like that. And in this close claimed analysis, the single most important factor leading to a failed airway was a failure to predict the difficult airway. So the prediction of the difficult airway is really a big issue. And in this recent close claimed analysis, inappropriate difficult airway management occurred in 73%, and 2 or more judgment failures occurred in 38% of these patients. So last question, what would you do with this surgeon? So.
I'm warning any of our human factors experts. I can see one wearing a pink jacket. I can't see Dr. Kelly or Professor Mendonca. I'll be coming to one of the three of you next to shut the doors. But anyone have a comment? What do you do with a surgeon who completely disagrees with your airway assessment?
Fantastic case presentation. Just my question is, before you have even started to do this case, have you had a multidisciplinary meeting with everybody in your hospital to say several opinions of your senior anesthetist, ENT surgeons? Because, you know, if your one ENT surgeon doesn't agree, another senior professor might have a different opinion. Your oncologist and everyone else sitting across the table to make a plan for this difficult case.
You're absolutely right. Multidisciplinary team meeting, we are coming on that. Thank you very much.
Thank you.
So does someone want to suggest how you tackle an obstacle? Because actually, we can debate very reasonably all day whether we should have swapped the laryngeal mask. We can debate all day whether you should jet or ventilate down a Forever catheter. But actually, the key component of this case is the surgeon would not believe you when you said this is going to be difficult. Where's a Professor Froak, do you want to opine on this, about how you train a surgeon? So that is an easy opinion, an easy opinion to have in this room full of airway people who would agree with you. It's a little bit more difficult when you're facing one surgeon, one patient, and have to make a decision. Did you have a good team debrief?
Yes, we did after this.
Did you use any naughty words to the surgeon?
Hello. I have an opinion on this, because I've been in a similar situation with a stroppy surgeon. I think you got to get the anesthetic body, your colleagues, to sort of back you up before you start the case, obviously. Because once you get to the position like you were, where you've already started and got into trouble, then it's a bit more difficult. So I think that's probably one strategy for dealing with the surgeon in that situation.
Really interestingly, nobody shouted that one out, I think, to get a friend, come and reassess the patient. But that's a challenge. Any more comments on this pretty horrendous case? Yes, I'm trying to see where the voice is coming from. Are you near a microphone so we can hear you?
No.
Did you take consent to do a tracheostomy?
Yeah, it was taken. Actually, this is an simulated, exaggerated scenario, not a real one, but it was taken, yeah. So. Yes, just refusal, yeah. So everything did not went like this, so I exaggerated to make it more discuss here. So.
Okay.
Well, I would like to mention that now the latest guidelines are more focusing on the human factors. So the Canadian Airway Focus Group mentioned the dysfunctional team dynamics. The components were poor communication, so inadequate leadership, a lack of shared mental model, and the solution was in situ multidisciplinary training by performing these meetings regularly. Because they concluded that they reported that the human factors were contributed in 40 to 100% of difficult airway adverse outcomes. And in this case, for our surgeon, for our department, we decided to perform more regularly the in-situ multidisciplinary trainings and discuss the cases all together before we got in any trouble.
So just to close, because we're 3 minutes before 17:15, how many of you, when you do your multidisciplinary training that people mentioned this morning, how many of you have your surgeons present when that takes place?
The registrars.
Okay, well, that's maybe the wrong meeting for that discussion, but somebody said up here they try, and that's hopeful. But one person in the room says they try to have this. I presume that nobody else has the surgeons present.
The registrars.
We do. Hooray! Because actually multidisciplinary training is exactly that. It's the surgeons and the nursing staff and the technical support staff or whatever. Someone is approaching a microphone with a comment.
I'm sorry to divert the discussion. Is it possible to ask the audience what percentage of them would have reached for the Sugamadex, even if I can say it in this microphone?
Now it's off patent and much cheaper. Who would reach for the Sugamadex? I'm not getting an overwhelming favour of Sugamadex. I think I can see a couple of hands up there, and not many others. So it looks like Sugamadex wasn't an option. Any other comments? Louder. It sounds very exciting, but I'm not sure what I'd say to my ODP. Can you get me the LMA that doesn't have a name yet? These things all have promise, but unless we use them and investigate them, I mean, just an hour ago, we all thought Thrive cleared CO2 until we learned that it didn't. So until we've done some investigations and some studies, we probably can't say this is a really good thing to use in an emergency. I have a pending emergency. It is now 1 minute to 17:15. Which obliges me to say thank you to Kamal for coming all this way and presenting his case. Thank you very much.
Thank you very much.
On your behalf, to our other three airway presidents, it just leaves for me to say a couple of things. Number one, I look forward to seeing you all at 8:30 in the morning for the DAS AMM. I know it's a very popular event. I'm sure there are tickets. There is a dinner this evening. And finally, because I know he worked really hard to be here and was very disappointed, what you've missed this afternoon is John Graham's presentation. We'll make sure that case report is available to you to download after the meeting, if that's okay with him. But we send him our warmest good wishes for a speedy recovery, and sorry that he wasn't able to join the panel. So on your behalf, thanks very much.